Hey everyone, thanks for joining Baltimore County Fire Department EMS Academy. For those who I haven't met, my name is Sean Randholtz. I am an anesthesia and ICU physician at Hopkins. I'm an active volunteer at Pikesville Volunteer Fire Company, and I have the honor of serving as one of the associate medical directors for Baltimore County Fire Department. On behalf of Dr. Pollack in the medical director's office, on behalf of the EMS office, Chief Shenning, Captain Stewart, Captain Fitzpatrick, thanks for joining us. Thanks for what you guys do every day. Thank you for your dedication to lifelong learning. A shout out to Ashley Brooks, who is a volunteer at Pikesville, who helps us with our IT platform. Ashley will put a link in the chat at some point during this presentation. Click on the link, enter some information. You can get your MIM CEUs. If you want your MIM CEUs, we'll announce it at some point. Ashley will put something in the chat. Click on that link. If you need a receipt for participation in the CEU, when you fill out that form at the bottom, there's an option to send yourself a receipt for participation in the CEU. Some have asked, expressed some interest in that. So tonight we're delighted to have with us Rebecca Freeman. Rebecca is a physician assistant in pediatrics. She graduated from the George Washington University with a Master's of Science in Health Sciences, Physician Assistant Studies, and a Master of Public Health. Rebecca experienced her first heart attack just before her 21st birthday as a healthy, active college student, and without an apparent cause. No diagnosis was established, and the event was essentially chalked up to bad luck. 8 years later, she had a second heart attack, that time resulting in a cardiac arrest. Thanks to incredible friends who quickly performed CPR and a great emergency care team, she survived and began both a road to recovery and diagnostic odyssey. Almost 2 years later, she met the doctors who could piece together her medical history, discovering SCAD as the cause of her 2 heart attacks. Today, she is doing well medically, active, 2 young children and husband, practices medicine, and is a board member of the SCAD Alliance. Rebecca, thank you for being with us. Thanks for sharing all of your your knowledge and expertise. We super appreciate you.
Yeah, absolutely. Thank you so much for having me. And it's an honor to be with you guys, especially not just through my medical training, but also, my experiences as a patient. This incredible appreciation for all that you all do. And I'm excited to be able to talk about SCAD today. So I am going to share my screen. Let me make sure this shares well. All right. You see that? Okay. So spontaneous coronary artery dissection, or SCAD, is what we're talking about. And what I titled this is the can't miss diagnosis in the patient you least expect. I know you all see tons of patients all the time, every day, that look, all sorts of different presentations. But if I am walking on the street, I'm probably not the patient you've expected to have had 2 heart attacks. And so I want to talk a little bit more about that. I'm going to start just with a little bit about SCAD Alliance, which is the organization I'm with, and myself, just, what authority do I have to even talk about this? Then we're going to spend the bulk of the time talking about SCAD, a couple of case presentations, and then what next? Where do we go from here with this knowledge? I know, again, you all see lots of things every day, and so talking about a rare, more, less common condition, let's think of some actionable things to do next. So I have no financial disclosures. So me, as Dr. Randholtz gave you a little bit of an introduction, I do have a medical degree as a physician assistant. And, so my involvement with SCAD Alliance is really the combination of a lot of my experiences. I do have medical training, like you said, though I'm in pediatric primary care, which, remember one time when I was in the hospital, one of the ER residents saying that is kind of the opposite of emergency care, just in terms of pace. But I have that background and have been working in pediatric primary care when I finally got the diagnoses of SCAD. So I use both of my events as cases later on in the presentation. I'll give more details, but one was in 2007 and the other in 2015. And for neither one of them was diagnosed as SCAD at the time. Both were diagnosed about 2 years later, in the 2016, beginning of 17. And so at that point, I started thinking, okay, what do I do? How do I combine these things? You know, I have training in medicine, right? I'm working in medicine, I'm seeing patients every day, but I also have this experience, this lived experience. And so the way, you know, for me to be able to bring those together was working with SCAD Alliance to be able to help with education. So SCAD Alliance, we are a nonprofit organization founded by survivors in conjunction with leading health professionals, with the mission of really raising awareness and advancing the research and the science of SCAD. So we do, as an organization, we were founded about 8 years ago. Most of our board is SCAD survivors or family members. And we work through programs with doctors, with cardiologists around the country to help advance the research. We have a large multi-center registry that we sponsor, and education. So we attend, you know, AHA, ACC, the major conferences to make sure that we are up to date and we're sharing up to date information about SCAD, and then also supporting patients and caregivers. One of the main things that we were founded on is this piece of collaboration and really working together with all aspects of care. So working with, you know, the cardiologist is who we think of as the beacon of any cardiac diseases. However, we also need to make sure we are working with primary care, pre-hospital, you know, family members, and industry, all these pieces to be able to really support patients. So SCAD, let's jump right into that. So I have here. So SCAD is, or spontaneous coronary artery dissection, is a separation in the artery wall. It's either with or without tear. So I'm not sure if you can see my mouse on here, but when you look at the in the top left corner, that is our normal, right? Normal healthy artery. And there's 3 layers of the artery. There's the adventitia, that outer layer, the media, and the intima is this inner lining. And typically what we want, what we're all hoping for right this second, is blood flow through the true lumen, no obstruction. In SCAD, what we have is some sort of separation of that arterial wall, of that intima, and that can either be with or without a tear. So you'll see right below the normal artery that has a tear. So what happens is when that layer tears, it shears off and creates a false lumen. So that flap right there, that tissue flap, can cause blockage. That causes obstruction and blood flow. There's also, you could also have it where it doesn't tear and just creates, you know, these other 2 images on the right-hand side of an intramural hematoma. Either way, what's happening is there's a blockage of blood flow. This is non-atherosclerotic, this is non-iatrogenic, this is not caused by, you know, catheters, other instruments, but it is still an obstruction of the blood flow. So this is, sometimes people like to see this as the full picture that I took it from. Anatomical appearance, I think, is a lot of times the easier one to look at. I did include angiographic and the intravascular appearances just for completeness. I'm not sure how many of us are looking at that on a day-to-day basis, but on the angiographic thing, the cardiologists love to see on here, you can see, especially under this type 2A, this long stringy piece that's in the bracket here, where there's not sufficient blood flow. And so about 50%.
Hey, Rebecca, can you go back and can you just point out to folks the picture, the intravascular appearance pictures?
Yeah, oh, absolutely.
Show what they're, yeah, because that's fascinating. Thanks.
Yeah, let's get here. So right in here, one of the things for the intravascular, so on this chart, it does have the different types of SCAD. In terms of treatment management, everything else we're going to talk about, we don't really need to get into those extreme details. But so on the intravascular ultrasounds over here on the right, let me pull up the ones on here. What you typically see is this translucent ring right in here where it's, I'm not sure if you can see my pointer or not, but actually on these 2 pictures. Okay, excellent, as I move it around. So you'll see this false lumen right in here. And so that's where, you know, blood is trying to go through on this area right through here. And so angiograph, I'll get to it later on too, is kind of what I guess gold standard for diagnosis, just because that's what's accessible and available. Intravascular ultrasound absolutely is also used, and you can see this diagnostic. It's really clear right there. Certainly, the thing on all these is you have to be looking for it too. All right, so SCAD can affect any artery, any coronary artery. About half of it does tend to involve injury to the LAD or the left anterior descending, and can cause unstable angina, myocardial infarction, cardiac arrest. This can cause, because we're at the end of the day, you know, while this is not atherosclerotic, this is causing an obstruction of blood flow. It's estimated to be about 1 to 4% of all acute coronary syndrome. But when you divide it into when you start looking at demographics, that's when I think it becomes even more pronounced that when we realize this is causing about 40% of heart attacks in women under 50, and is the #1 cause of pregnancy-related MI. And when pregnancy-related, different studies, so most of this data is being pulled from different studies at different institutions. Most of those pregnancy-related MIs are in the 3rd trimester or in the first 5 to 6 months postpartum. The big thing with this is that rapid nature of the arterial separation, that quick separation and dissection, and the resulting cardiac damage definitely makes this an urgent condition and something that needs to be identified. SCAD does affect all races and nationalities. I put on here the disclaimer that true prevalence is unknown, in part because of a longstanding lack of recognition. But we are, so a lot of these studies are pulling, from each institution, pulling together, 1 or 2 or 300 patients usually. But for the most part, they're all showing about 80 to 90% are female, about 10 to 15% of women are in the peripartum period, with an average age of in the 40s, right? In terms of cause, we really don't have a great answer for this, which is frustrating to both patients and healthcare providers. Most are idiopathic. There's not an identified genetic mutation. Because the majority of patients are female, there's definitely, everyone pretty much agrees that there is a relationship between hormonal cycles or medications like oral contraceptives, as well as hormonal changes throughout pregnancy. But that exact relationship hasn't been confirmed. And then the other interesting part is that most patients are experiencing some sort of hormonal, physical, or emotional stress. And this is a tricky one. I know when we first started getting to the actual naming the diagnosis as SCAD, that can be a tough one for people because you can very easily translate that into you had stress and you caused this. And there's also that question of, well, lots of us have stress, right? There's lots of times that we've had just a ton of craziness in our life and haven't had a SCAD. And so for most of the patients, it's really thought of as being that perfect storm of, maybe it's a certain part or a certain time in the menstrual cycle, a certain, more stress than others, than some other piece, and just a susceptible artery. In terms of related conditions, there's not a direct relation to traditional cardiac risk factors like atherosclerosis and hypertension. There is a strong correlation to fibromuscular dysplasia, or FMD. About 80% of SCAD patients also have FMD. FMD is a arterial condition that is non-inflammatory, that it causes kind of beating throughout, usually tortuous vessels throughout the entire body. There's definitely been a suggestion that there's a relationship to inflammatory conditions like vasculitis and inflammatory bowel disease. Again, not a specific, direct link. And then certainly, I add in here for completeness, patients that already have an increased risk of arterial dissection, such as, patients with genetic connective tissue disease, VEDS, Marfan-Lou-Dietz, Certainly those patients have an increased risk of SCAD because they have an increased risk of all arterial dissection. But when we're looking at SCAD patients, the majority of those patients who have had a SCAD heart attack do not have a genetic connective tissue disorder. So in clinical presentation, what I think really identifies this is this idea of the atypical heart attack patient, but it's really not atypical symptoms. I put on here, and again, the image, the top image shows our blood flow through a normal cross section of an artery, and then the two kind of ways we think of SCAD, either the flap, this intimal flap, or a hematoma. And then also this picture of atherosclerosis. Okay, it is absolutely a different mechanism, but we're still causing disruption to the blood flow. And so SCAD symptoms, like with heart attacks from atherosclerosis, definitely directly relate to the extent of coronary artery damage and blood flow impairment. And when those changes in blood flow cause blockages that lead to muscle death, symptoms are the same as those with the typical MI. So I put them on here. I know you all are probably the people in the world who know them, who could recite these all in your sleep backwards, upwards, and down, but that chest pain, pressure, tightness, heaviness, but also all of these other, the dizziness, the just not feeling well, the sweating, the just really tired, headache, something's wrong. Like heart attacks from other symptoms or other causes, symptoms can be more difficult to recognize in women. Let me go back to that. And so really it takes, and I feel like I harp on this a couple of times throughout this, but it takes having a suspicion of cardiac problems to say, maybe could these things be related to this? Maybe could this be SCAD? Certainly I know that you're probably looking at these saying, yeah, I see these all the time, both in patients who have traditional cardiac disease, as well as patients with anxiety, patients with reflex, patients with all sorts of different things. I know that's sorting these out, but this is it. This is what we're doing. So in terms of how the patients are presenting. Diagnosis, for first line EKG, echoes, troponins all measure cardiac damage. And so, I know those are absolutely the things that are done first line to recognize, okay, we have a cardiac problem. They're not diagnostic for MI from plaque rupture versus MI from SCAD. So coronary angiography is what's most often used, simply because that is also what's available in most centers. Again, you do need a level of suspicion. A lot of the cardiologists who see a lot of SCAD patients do work very closely with the imaging teams at their hospitals, just about identifying these, being able to see those subtle changes on angio. The IV intravascular ultrasound and other imaging can absolutely also be used. One thing that we do note is that accurate diagnosis or finding out, so okay, you get troponins and say, all right, this, there's some sort of cardiac damage, but having that accurate diagnosis is important because management and workup from there do differ between MI from plaque rupture versus SCAD. So again, treatment is guided by the severity of symptoms. For a lot of patients, spontaneous vessel healing can occur naturally. Usually it's over a period of several days to a week or so. Stable patients without severe symptoms can be managed with close observation. Almost always that is inpatient, because if that dissection continues, if that muscle damage continues downstream, we move to the next step in this, which is, sometimes dissections do require further intervention. There's definitely some evidence that PCI, so angioplasty and stent placement, are less successful in patients with SCAD, given that oftentimes the arteries are more susceptible to further dissection and further tears. But again, for each patient, sometimes you're in a situation where that's what's necessary. If you cannot maintain blood flow, you're going to have to, you can't sit there and wait for hopeful spontaneous vessel healing. This, I thought they put it very well in the scientific statement from the AHA, is looking through here. So for patients who are stable, generally people really try to work towards that conservative therapy, monitoring as inpatient, making sure that symptoms are resolving, patients are feeling better, and then just before discharge. But if not, then you're going on to these other more invasive steps. The other thing, just kind of in general for management, a recognition that SCAD does recur. So we're wanting to make sure we're setting these patients up for being able to look into, while we don't have a cause or something we can say, hey, if you don't do XYZ, you won't have another SCAD. Being aware that, hey, this has happened. If you have similar symptoms, we need to have that evaluated in the emergency department sooner than later. Beta blockers do seem to prevent recurrence. Cardiac rehab is really critical for patients who have had SCAD. I think I'm biased, I think cardiac rehab is phenomenal and wonderful, but especially I see it being especially beneficial in patients who have had SCAD because the fact that this is not the typical patient. These are patients, in general, stereotypically women in their 40s who have been running and doing and just taking care of life. And then for the first time, all of a sudden, out of nowhere, their body has betrayed them. And so cardiac rehab is really important for helping patients trust their body again, figuring out what they can do, what they can, how they can manage things, how to trust their body. Seeing a SCAD or vascular specialist, and usually genetics is usually considered, although it's a very small percentage of patients who have that identifiable, connective tissue disorder. That is definitely a time to go ahead and start looking, right? We're not screening the general population for different genetic conditions, but once somebody's had a SCAD, it's absolutely worth reviewing your family history and seeing if that's appropriate. So
there is a question in the
chat.
I
was going to say this is probably a good point.
It says, why not put in some kind of reinforcement to the vessel to be proactive?
To be proactive?
I guess before the dissection occurs.
Yeah, I think it's because we don't really have, there's not a way to identify, hey, these are the patients that are at risk for SCAD in the general population. And then also while there are some areas, we can say, LAD is more, it's more common to have a dissection there than other places. It really could be anywhere in the entire coronary vasculature. And so we wouldn't really be able to do that effectively, I think.
And whenever you put something in, like a stent, right. Now you're committing to lifelong anticoagulation and dual antibiotic therapy, certainly carries risk. Right, absolutely. So there's some other questions. I don't know if you can see them.
Yeah, I was gonna say it's probably a good time, and then I have any cases and what next. So I see one. I was gonna say I can see some of them.
Great.
One says, does a thrombosis cause the tear? No. So truly a spontaneous rupture. Hypertension, yes, as a potential cause, not. So certainly if somebody is extremely hypertensive, you have increased arterial stress. And so that could, not in the same sense that when we talk about traditional risk factors for traditional cardiac risk factors, hypertension causing that long-term stress. So not quite in the same way. Does that make sense? Mm-hmm. Let's see the other ends. Local hospitals specializing in SCAD. Yes, absolutely. I have a slide at the end and I will show it. So as an organization, we do not maintain, a comprehensive list of these are the SCAD specialists in the country. However, what we do have is we are coordinating a multi-center registry. We have 17 sites currently and more enrolling. I think we have 4 onboarding right now. And it's really great to be able to build the research base with that. But one of the other great things is that we know that those sites are committed to SCAD research. So Hopkins is on board. I'll double check my map if they're fully on board or if they're still onboarding. But that is definitely one of them. So there are a couple there. Generally, adult cardiologists, I think the youngest, while this can happen kind of 18, 19, it tends to be more 40s. And so I know, while technically when I was 20, I probably could have seen pediatric cardiology, I was seeing adult cards at that point. Let's see, is there an association with section? Not necessarily for so the question, sorry, was, is there an association with or increased risk for aortic dissection? Not necessarily, certainly in the patients, with genetic connective tissue, beds, Marfan Lodites, those patients, but not with the coronary, not with SCAD. Does it only occur in coronary arteries? It tends to, and that's kind of one of the interesting pieces. And I think one of the really important reasons to be in a vascular center, to see a vascular specialist, and really do that workup for, do you also have fibromuscular dysplasia? Is there any genetic, diagnoses that we need to pursue? Because those pieces would indicate more systemic involvement. Yay, Shannon Conley. As an EMS, I love this question, right? Because as an EMS provider, when assessing a patient, what signs or symptoms might I directly report to the ER doc upon transfer care that might flag the doc to consider SCAD as a possible cause? That is like my last 3 slides, because I think that's really the crux of this, right? Is how do we, in the field, I recognize that you don't have like a CT scanner in the back of your truck, right? You're not going to be able to say, hey, this is a SCAD patient. I really, really think that having even a suspicion for cardiac causes is what gets these patients on the right track. So often patients are, you just don't think that it's cardiac. You think that it's 1,000 other things. And a lot of times it probably is other things, right? I know you probably see tons of patients who don't have cardiac causes of weird symptoms. But I think really emphasizing that I have a suspicion this could be cardiac, given their age, given their, that medical history, that's not just the typical cardiac medical history of, oh, do you smoke, do you drink, these things. Obviously, I know you're not doing a full genetic history in the field, but I really think passing along that suspicion of cardiac causes. Randholtz, I'm not sure it's a Philipson after lesion occurs. Oh, are you seeing for, somebody said I meant after a lesion occurs to prevent further damage. I'm guessing with the asking if you should preventatively put in a stent. I think it kind of brings up that point of it, we don't know, it often causes more damage if we already have these friable arteries. Those are the ones that I saw. Were there others that I should?
The only ones I see also. Okay,
awesome.
Cool. Good questions, you guys.
Yeah, this is awesome. So what I did is for cases, this is me, okay? So this is not supposed to be a surprise quiz that the answer is SCAD. But so for my first one, I went ahead and shared kind of my story because I think it was really illustrative of how important it is for somebody to just think cardiac. So I was a 20-year-old college student. It was 2 weeks before my 21st birthday. I was healthy, I was active. This is like 2 weeks before. I ran a ton. I was just doing my thing. And I worked as a campus first responder. And we were, I was on call one weekend. We had a call, it was intoxicated freshmen, right? We had this policy that I don't even remember the exacts of it, but you had to call county EMS, and then they had to wait for campus, public safety. So essentially it was a no stress call, but a lot of waiting. And I remember vividly standing there talking to, with the two county responders and saying, like, something is weird. Like, I just don't feel good. Like, I just kept doing this, like, something's off. Like, I can't get a good breath. Like, something's weird. And kind of between the three of us, it was like, I don't know, did you eat something weird? Did you go for a longer run than usual today? There's any number of things that could just make you feel a little weird, especially when you're a type A pre-med student in college, right? Vitals were all normal. I went back to the health center, it was like, the vitals were like, okay, it's fine. The next morning, so this was late at night, the next morning, my roommates kind of said, hey, you got to go to the ER, like, just to get checked out. And they put it in quotes because that always cracks me up of like, just to get checked out. Clearly, once you're there, you're getting checked for something. Somebody has to have a level of suspicion for something. But it was just like, go to, like, well, just get something figured out. I still don't feel well. Go, just lots of waiting. My friend who was with me still laughs, like, first urine drug screen was negative. Of course, that's the first thing we need to do, right? And a college student with weird, vague symptoms. Repeat serum drug was also negative. I meant to put my actual troponin value in there, but with, so when they did the serum drug screen, obviously we're doing a full, a little bit larger lab panel at that point. And troponins were just sky high. And my now husband, who I was dating at the time, talks about how, we were just at this point all waiting. None of us thought this was a big deal. It was all like, something's weird. We'll get Rebecca checked out. I don't know, maybe you're dehydrated. Everybody in the ER was very chill about it, lots of waiting. And there was one point where we were waiting on results, and I must have told him, I'm like, listen, I don't feel good. Like, something is bad. Like, I hurt. And so he went out in the hall to kind of just check on what's going on, where things, and he said he just remembers this barrage, 5 or 6 medical providers coming down the hall. And it was the moment when everybody realized, this is cardiac. Like, none of us had any idea that this was cardiac, but those troponins came back and finally did an EKG showing the ST, showing SEMI. And so we went to the cath lab, no occlusion, no stent at that point. And that was kind of the weird thing, is this diagnosis, we kind of all had this moment of like, what? Like, are we sure, like, cardiac? Like, where are we at? We know this is a heart attack because of the damage, but we don't know why. We're going to diagnose this kind of as bad luck. The problem with that is the treatment plan is you cross your fingers and hope for good luck. And I think that, so we at that point did not know that this was SCAD. We knew it was a bad luck heart attack. And I was discharged with typical your aspirin, beta blocker, statin, because we didn't really know even what else to do. So I think in this, for my first one, it was really that it would have been, we really needed somebody to say, cardiac, can we think cardiac? Can we do an EKG or troponins or something early on? Given that in retrospect, I felt weird, but I also had numbness, tingling. I also had that shortness of breath, some of those key symptoms that, if I had been an 80-year-old overweight smoking male, would have immediately triggered, the idea that this could be cardiac. So for me, we had this, we kind of all said, this is really bad luck. I went through cardiac rehab. I started running again. We never knew what was going on. And then 9 years later, so I had all sorts of workup. Nobody really had any idea. 9 years later, after my second pregnancy, I was out running with my running group, and I guess I put a few more details in here. So 29 years old, I was 5 months postpartum, healthy, active. I had just secured my first job as a PA. This is my last day with my running group, and we always did a out and back run. And so at this point, it had been 9 years since I had had this weird heart attack in the past. I'd already had 2 pregnancies. We were good. Nobody thought it was a big deal. And so we came back from our run and I collapsed. And I don't remember any of this, of course. But, so of course, everybody's first thought is it a seizure? Is she dehydrated? Like, what's going on? Somebody had the wherewithal, somebody incredible, not just somebody, but my incredible friends had the wherewithal to check for a pulse. And of course, I had no pulse at that point, and they immediately started CPR. We were on military base, and so EMS was able to get there within about 6 minutes. So I think they only did about 6 or 7 minutes of CPR before being shocked from defibrillation. And so this one, and part of why, we think for this one that I had such a significant event is really that combination of things. Really, you're hitting yes, there was some stress, but I was also postpartum. I also had pretty significant cardiac damage, apical damage from the first heart attack, probably because it wasn't recognized for 18, 20 hours. And so for this case, I put it on here. Nobody at this point recognized that this was SCAD, okay, right? In this kind of case, as I think all you know even more than I do, the presentation is totally different. The management is totally different. You're just trying to stay alive at this point, right? This was not diagnosed as SCAD until about 2 years later, when we were finally kind of no longer putting out fires, and we could finally say, okay, what is going on? Let's look at your medical history. Let's review all your imaging. In this moment, when I presented here, when EMS got here, we're not trying to identify SCAD. We already know this is cardiac clearly at this point, but it just kind of shows that next, what can happen too. More typically, presentations are these patients, your best friend, friend who ran a marathon last weekend, your colleague who's got a lot going on, new mom who's like, something's not right with my body, like something is going on. And so sometimes you'll have these, like my second one, where it's just very, very obvious nobody's gonna dismiss cardiac concerns at that point. Or you have like my first, that is not what's first on your differential by any means. Often SCAD is dismissed as anxiety, stress, heartburn, anxiety. I put this on here purposely multiple times, costochondritis and anxiety, right? And again, I keep harping and coming back to this circle because I know that we see people with anxiety, right? I know in primary care, in the emergency room, in pre-hospital, we see people with all of these other things too. But we also you just have to remember that it's not 100% these things. There are definitely times that it is also cardiac. There is, the other kind of piece of this is there is certainly a lack of awareness. As a condition primarily affecting women, there is, it's less recognized, less research. NIH is pretty straightforward about the fact that the majority of research still is done on male subjects. And so we don't, in a condition that primarily affects women, we don't have as much research on this. SCAD is considered a rare disease because it's often overlooked and underdiagnosed. And then again, at the front lines, like SCAD patients overwhelmingly don't look like the typical cardiac patient. And then you can layer on too all the social emotional pieces of this that, if we're talking stereotypically, at least among this demographic, right, 40-year-old women, we're running around. I'm taking, coordinating schedules. I've got my kids these places. I don't have time to go to the ER. Like, this really isn't, a lot of times women are taught, women's healthcare is about, ovaries and breast cancer, right? But there's also a heart there, right? There's lots of other body systems. So there's also this among women, or among, and I say women, but certainly this affects guys as well. Among all humans, being aware of our body and knowing what's going on and recognizing, hey, something's going on. So yeah, the next part is just kind of where to go from here, right? Like I experience, say, hey, there's this rare condition, don't miss it, please. But what's, what all is going on? So one thing, I've said a couple times that we don't have perfect research. Our organization, SCAD Alliance, sponsors a multi-center registry. Right now we have the 17, let me see, is Hopkins. So Hopkins must be onboarding right now of sites. And one of the neat parts of this is that we're getting, when you take something that, so even at like MGH, where they're seeing, tons and tons of SCAD patients, we're really getting like 100 or 200 a year, right? But if we combine that, if these, clinicians combine that across the country, we can get very robust data sets. We've been enrolling for just at 2 years this spring and have, I think we're almost to 700 patients. And we can get a little bit more diverse data too with, some of the very early sets were very, very heavily peripartum patients. And because that's who, it was the cardiac OBs who were recognizing and doing this. So we can get some more diverse data. The other thing, and I kind of addressed this with questions, but the other really nice thing about this is we're more, not specifically creating centers of excellence, but more or less, right? We're having, we're identifying places around the country where we're able to say, hey, there's a medical team here that is very aware of this, that's, in their hospital systems, communities are increasingly aware. Another thing is, with these researchers, so are really putting together, and we just are always talk that we just are so privileged to work with amazing clinicians. Our scientific advisory board just works tirelessly, both seeing patients and working to advance the science, putting together things like the scientific statement through the AHA 3 years ago now. And then the other thing is working with pre-hospital. I don't know if everybody saw the article a couple weeks ago about SCAD, and really working with our community to say, okay, we just need people to have this suspicion, right? EMS is really who is identifying for a lot of patients. You guys are that saving grace for so many patients, because it's that first person who says, hey, like, this is a problem. Like, I'm glad you called. Let's go get this checked out. Let's, make sure that we actually do something about this, that you don't necessarily let us continue to dismiss our symptoms. And so really working with pre-hospital providers has been really critical in identifying patients. So, the last thing is this idea that there's absolutely, one of the nice things, I guess, one of the really hopeful things that I can leave you with is that there's absolutely improved outcomes through diagnosis, right? This is a more rare condition. However, just being aware and having a suspicion improves outcomes, helps patients. I adapted this from Michelle Westfall's article from the Journal of Emergency Medical Services, because her summary in there was just really great with these reminders, right? Is that really just remembering nobody is too young or too healthy for a cardiac condition. Right? If somebody presents with cardiac symptoms, at least consider cardiac. And I know that there's lots of other things that you're also considering, but at least keep cardiac on the differential. Maintaining a high index of suspicion for SCAD when responding to its most prevalent populations. Thinking about, okay, yes, there are lots of things. If I were to say, okay, 30s, 40s, 50-year-old women, healthy women, I'm sure there are other things that you more commonly see. But SCAD needs to be on the differential there, especially that population. Again, this reiterates this, but reminding that every presenting complaint in a pregnant woman is not pregnancy related. I know that can often be the case that things are pregnancy related, but not always. They still have other working body parts, hopefully. And then, of course, the last one too, not assuming that previous diagnoses are correct. Lots of times, we'll hear that patients have been discharged from the emergency room with a diagnosis of reflux, or with an anxiolytic, with something like that. And then they call again because they're still having symptoms, and don't just build on that previous diagnosis, because oftentimes that's not up the crux of it. And so those really are kind of those things, is having a suspicion, right? That's really the biggest thing I leave you with, is if it sounds like it could be cardiac, consider cardiac. Nobody's too healthy, too young for these things. So that is the bulk of what I have. I have on here are ways to get in touch with us. I was going to pull up the chat to see what else people had, what other questions, and then let's see, or Sean, if there's others that you see too.
Thanks. That was great. Thanks for sharing that.
Yeah, absolutely. Let me pull up for...
So I had a question to kick us off. So
Yes.
It's not just about providers identifying that this could be potential cardiac, right?
Mm-hmm.
Because in your first case, you went on to angiography and SCAD still wasn't identified. So what is the gold standard diagnostic test for SCAD? So
the angiography with a somebody looking at that imaging who suspects SCAD, I think, is the next piece of it. When looking at my imaging in retrospect, SCAD has been diagnosed. So when you're looking at it, you're looking quick, you're not seeing, and I also recognize too that I am, have not been in that space, like, right, you're also trying to manage the clinical presentation of that patient at that point too.
Yeah.
And so sometimes I know after the cardiac arrest, I think we're laughing about, there's like 2 images total. Like, it was like, quick, get you back on hypothermia. But yeah, so angiography with somebody who suspects it.
What about coronary CTs?
Yeah, those are actually done too as well.
As a more recent technology. I just wonder what the guidelines say about, from American College of Cardiology, say about the evaluation of an MI, right? So once you get to the point and you say, okay, the troponins high, or you have a STEMI, and then you go on to testing, does that recommended testing explicitly talk about SCAD?
Yes, let me pull up. I have the scientific statement too, because in part of what they're saying in there is because that is more available and more commonly read and interpreted. Mm-hmm. That is what is typically used.
Got it. Cool.
Standard imaging method, given its spatial resolution, and it is a definitive test to diagnose. I was looking through to see if it. Go through on here.
Hey guys, we put in the chat the link for your sign-in for your CEUs also. And if you want a receipt for participation and you click on that link, fill out some information at the very bottom. It says, if you want a receipt, click this button and it'll send you a receipt as well. One of our paramedics, Brian Carhart, asked, what does the beta blocker do for SCAD patients?
Yes, and I am trying to remember pathophysiology too. And you could I'm going to pull up this too, because I believe it also decreases contractility. Let me see. I'm going to read through. Dr. Randholtz, if you want to add to from
yeah, I think that it decreases metabolic. So this is
decreasing load,
similar to any coronary disease, whether it's a thrombus, whether it's a dissection, whether it's a SCAD, whatever that may be. The point is that causes decreased end organ perfusion and myocardial injury. Beta blockers decrease coronary work, right? So it decreases contractility, it decreases heart rate. Heart rate in particular increases myocardial oxygen consumption and increased myocardial oxygen demand. So it's the unfortunately hits on both sides of that balance. So, and also I think there's some evidence, perhaps, correct me if I'm wrong, Rebecca, beta blockers also may have some impact on remodeling, or is that just ACE inhibitors?
I've heard there's some, it's definitely, because, so I actually also have that. So I could have hit some of these multiple categories of things, but it does. And a lot of this, data is extrapolated to from, not necessarily, we haven't had, a randomized control trial that says, hey, in SCAD, patients who have had SCAD, this is great, but it's using that mechanisms of it. Because generally people do go with the beta blocker because I do think it has some impact on remodeling, certainly less than ACE inhibitors, but in terms of other medications, post SCAD, I think I touched on, the fact that I was put on the aspirin and statins, and there's really not a specific role for those. In my case, it was because we were still calling it bad luck. At one point somebody asked, is it vasospasm? Is it, any of these other things? And if you don't really know what you're treating, you can kind of get away with standard medications, also 15 years ago. But at this point, definitely, if cardiologists agree, certainly if somebody needs statin therapy for other reasons, by all means, address that, but not specifically post-SCAD.
Any other questions, you guys?
I don't think I see any more.
Sean, could I make a comment?
Please do, Nikki.
Yeah.
Please. So I wanted to thank you for your comment on cardiac rehab in women. I used to work in cardiac rehab. I did my doctoral dissertation on cardiac rehab in women. And it's really profound what happens with women and the benefit that they get after these cardiac events. And we know that women are under-recognized and under-referred for cardiac rehab. And it's fabulous. And then when they have issues in cardiac rehab, EMS will show up and take care of them, but it's fabulous. So I just wanted to take a shout out and thank you for that chat, because there are lots of women out there who really need that information.
Absolutely, thank you. And for the cardiac rehab piece, I think, like you said, it's just, and I actually went through it 3 different times. And so one of them,
good for you.
Well, and for different pieces of it, and could see different benefits from it. I think after the first one, it was like, well, you were a runner. Let's try to get you back into what you were doing.
Right.
For this second one, it was post cardiac arrest. So it was also like, let's get you walking and moving again. And then the third one was actually 2 years later when I was healthy. I was working clinically when we diagnosed SCAD as the cause of these things. It was more of an opportunity to trust my body and learn what I can do. And so being able to see those benefits, I think, are really, really important for all people. But I think it was very easy. It would have been very easy to say, no, I'm too busy. Like, I can't find a babysitter.
Women are good at that. Yeah. So good for you. Thank you so much for your comment.
Oh yeah. Thanks for being here. Other questions?
That's all I see right now. So I just, again, like Nikki, I want to echo and just thank you. Thank you for sharing your story. Thanks for spending your time here with us. Thank you for your work in healthcare. And thank you for pulling together this really powerful network of patients and a cohort of patients with SCAD across the country, and that work to advance the science. It's really quite innovative, and yeah, it's beautiful that you're working towards that, creating that community to try to help advance that science.
Thank you. This has been great. It's always really exciting to be able to share that, share the information, and have people who are interested in hearing it. So thank you.
Thanks. I super appreciate you, and have a great summer with the kids.
Thank you.
Bye-bye.
Bye.